everyone. Thank you for attending this lovely in-service. Corinne is here, and I think we're about ready to get started.
I know there's some faces in here that are newer that I probably haven't seen yet. So for anybody who doesn't know me, I'm Corinne Fisher. I'm the intensive care unit pharmacist. So we're here today to talk about medications commonly used in the unit. Some of this stuff may not apply, just kind of wanted to hit the broad stuff so when you are on rounds, you kind of know a little bit about what we're talking about and what are higher doses or lower doses and how it affects the patient. So I went to St. Louis College of Pharmacy, which then was USHP, which is now WashU. They keep changing names. And this is my 20th year as a pharmacist, and I've been in pharmacy a total of 26 years. And I've been in the unit for 10 years now. So as you know, some of our doctors are really good about following the ABCDF rounding, which kind of addresses the patient as a whole and all of their care needs. Some of our other physicians don't follow that as much, but this has been shown in studies to improve patient outcomes. So that is why we do that. So the A, obviously we're assessing, man, I can hardly see that.
I know.
See that on here too. We assess, we prevent, and we manage pain. So we're talking about the patients on any pain medications. If the patient's on like a fentanyl drip, or if they're also partly if they're sedated. The B is more for the respiratory therapists, our breathing trials and our awakening trials. And then also C is our choices, sedation and analgesia. Once again, like if they're on propofol, Cresidex, basically what we're using to sedate them. We're also assessing delirium, which we know this is really common in the intensive care units. And also, here's where you all come in, is our early mobility and exercise to get those patients moving. And then finally, family. So we're gonna kind of break this into just a few sections. We're gonna talk about vasopressors and sedation, paralytics, delirium and pain, and then also our thrombolytic and anticoagulation reversal agents. Okay, so to start, we have our vasopressors and inotropes. Vasopressors increase blood pressure by constricting blood vessels, like vasoconstriction. So, you know, basically if you think about if you have a tighter hose, the water is gonna come out quicker. So your blood vessels, if you squeeze them, it's gonna increase blood pressure. Our inotropes are to strengthen the force of the heartbeat. So actually causing the actual heart itself to contract harder to increase blood pressure. Some vasopressors also are inotropes. So not only do they cause vasoconstriction, but they also cause the heart to contract harder. So as you all probably know, we like to keep our mean arterial blood pressure from 65 to 75, our systolic blood pressure greater than 90, depending on the patient's condition and the physician orders. And we like to run them through a center line because there's a really high risk of extravasation and damage to tissue if they're run through a peripheral line. So we try not to do that. So if patients are on a vasopressor, they're gonna be in the intensive care unit. So we have a few different types. I'm just gonna run through these really quick. Probably more of what you need to know is like higher doses, the patient's more critically ill. The increased number of pressors they're on, also the patient's more critically ill. But we'll just run through this really quick. So our norepinephrine is the one we use generally the most, especially if a central line's available. Our first agent is usually gonna be norepinephrine. It affects the alpha and beta agonist receptors. So our normal dose is gonna be 0 to 0.5 to 2 microgram per kilogram per minute. If you see it at that higher range, or even sometimes even higher than that, then the patient is really unstable. They're not doing well. It increases heart contractility, also heart rate and vasoconstriction. So we're gonna use this in shock and post-arrest. Phenylephrine is more just our vascular resistance. So more, instead of just the heart, it's gonna be more of your vasculature. So patients that are in heart failure, we don't wanna use this because the idea of if your heart isn't very strong and you're increasing the pressure into the heart, you're not gonna get the blood pumping back out of the heart like you should. So we avoid this in heart failure. This is really good for hypotension and vasodilatory shock. Patients that basically have really low systemic vascular resistance, this is exactly what we're using it for. Okay, epinephrine, our normal dose also with this one, once we get up to that higher range of the 0.8, the patient's really unstable. Usually this is gonna be added on in addition to other pressors, unless it's anaphylaxis, and then that is our go-to on epinephrine. If you think about like an EpiPen, then we're gonna be doing an epi-drip for patients that have anaphylaxis to try and get rid of that reaction. And it also relaxes smooth muscle of the bronchial tree, so that's also why it's really helpful in anaphylaxis. And then finally, vasopressin, which we call vaso. That one's at a pretty much a set rate. It works totally different. We usually add this on to norepinephrine once we get it over the 0.1 microgram per kilogram per minute to kind of help them work together. And it also increases systemic vascular resistance. Okay, so our inotropes, go through these kind of quick. Dopamine, we have a few different types. Basically, they're all for different purposes. Our dopamine, dobutamine are used more in heart failure. They're gonna cause the heart to actually squeeze harder. So that's why it's good in heart failure to increase the blood pressure. And then milrinone is really good for right-sided heart failure. So that's what, when you see that, we don't use a whole lot of it, but when you do see it, it's usually a patient that's right-sided heart failure. And then finally, our isoproterenol, and this is for our patients that are usually waiting for a pacemaker that are bradycardic, and this actually helps stimulate the beta receptors, and it increases the heart rate. And it doesn't have a whole lot of effect on blood pressure, so that's why we see that sometimes, like usually they'll start the patient on dopamine or dobutamine, and if the patient develops an arrhythmia, they'll put them on isoproterenol. And usually it's just for a few days because it's $10,000 a bag, so we try and get that off right away. Okay, so these are the higher doses I was talking about. Once they get up to these doses, the patient's not doing really well. You know, we're not wanting to move them around too much. We don't want to rock the boat.
Greg, can I ask you a question?
Absolutely.
So, you know, they put therapy orders and PT and all three, we put our recommendations in the chart, right? So, when you're sitting at your desk all day, do you like sit there and open everybody's chart up and just start looking at their vitals and?
Yes, I look at every single patient's chart every single day.
I figured.
So I can kind of go in and see if anything needs to be tweaked.
Cause, I mean, okay, so I would think you look at that multiple times each day, am I right or am I
I mean,
wrong?
anytime that I get an order, I'm in the patient's chart kind of reviewing their meds,
Okay.
just to see if anything needs to be adjusted or changed. But the nurse is adjusting all of these based on the patient's condition and their MAP and their heart rate, and depending on what we're treating, the nurse is in there constantly changing it,
Okay, so the nurse
based
can
on
adjust-
parameters.
So the nurse can adjust dose, okay.
Yes, so we enter it as a titratable drip with a range, and it has parameters on it. So it will tell them where to start, how often to go up or down, and by how much, and then it has a goal parameter. So if, say the patient's MAP falls to 55, they're gonna look and they're like, okay, I can titrate this by 0.01 every 10 minutes till I hit my goal. So they'll be going up and down all day. And then we also talk about it on rounds, like what the patient's rate is,
Yeah.
and that's kind of clue on how much support they're actually needing.
Yeah.
And then this is just a handy dandy little chart if any of you wanted to see like actually how the pressors work, and depending on which receptor they hit, they kind of all work a little bit different. I just like visuals, so that's why I included it. Okay, so our sedation, this is where I know some of you probably want to know a little bit more about, because this also is really important to how quick we mobilize a patient. So sedation, I kind of have it as like the strongest to some of the weakest, and propofol in pharmacy we call it milk of amnesia, because it looks like milk because it is a lipid drug. That's why it looks like lipids, why it looks like milk, because it does have fat in it. So it's really short acting, it's a great sedative, but you absolutely have to be intubated. Patient, if you're not intubated, this affects the respiratory drive and they can die. This is how Michael Jackson died, actually. So he had a doctor that was giving him this and wasn't paying close enough attention, and he got too much, and he quit breathing and he died. So Yeah, so propofol, when a patient's on propofol, we monitor them very close, yes.
The word lipid just kind of, my
Mhm.
curiosity rounds, you always ask.
So
about-
this is why I'm always asking about triglycerides. The problem with propofol is if you are running it at a higher rate, and especially if the patient is larger because it's weight-based, you're getting a lot of lipids every day. I mean, you're getting a lot of fat, and it can cause the triglycerides to spike. So if I see a patient on like a higher rate or is a larger patient that equates to multiple mils every hour, I will ask for a triglyceride. And once our triglyceride's over 450, we find something else because it can be really harmful. It actually can cause what's called PRIS, which is PRIS, propofol-related infusion syndrome. And usually one of our first clues is those high triglycerides. But it can basically cause multi-organ failure. So that's why we check it and why I'm constantly asking for triglycerides on rounds. So that's kind of our big gun. That's our deep sedation med. Then we have Precedex. Precedex we can use without the patient being intubated. It does not affect the respiratory drive. Now it can cause some pretty severe bradycardia, and propofol can also, but we see it more commonly in Precedex. The other problem with Precedex is every now and then we see it cause fevers. So sometimes we'll be on rounds, like they're on appropriate antibiotics, but we switched to Precedex yesterday and now all of a sudden they have a fever. And I'm like, well, it's probably the Precedex. So it can actually cause fever. But what we love about it is it also works to help a little bit with pain, especially good in patients with alcohol and drug withdrawal. So it's really, really good for that patient population. And we also have ketamine. Ketamine can be used for multiple things. Higher doses, we can use it for rapid sequent intubation. It can be used for pain. It can be used for agitation. We can use it as a continuous drip to help a patient with their sedation, especially if they can't be on propofol because their triglycerides spiked. We can try ketamine. Ketamine can cause some arrhythmias. It can cause tachycardia and bradycardia. More so tachycardia. It can also increase blood pressure. But what's really odd about ketamine is sometimes it causes the patient to hallucinate. So if you're in a room working with a patient and you see they're not quite acting right, maybe they're on ketamine and that might be the cause. But it's a great drug. It helps us a lot, especially in patients that we can't use other things. And since it doesn't affect the respiratory drive, we don't have to worry about the patient being intubated.
I have a question. When it comes to like the elderly patients and they give them sedatives, I thought I've heard psych say like there's one that's just not good for them and it usually makes them a lot more confused.
Benzodiazepines.
Oh, okay.
So lorazepam, midazolam, it does. And actually, I'm about to get to that. So
perfect.
that's one of our next ones.
I had a quick question.
Yes.
So on like propofol, Precedex, ketamine, I know it varies per patient, like on dialysis or something, but like how long are they usually in their system after?
So the
stopping?
propofol has a really short half-life.
Okay.
So, and it's not necessarily affected by your kidney or hepatic function,
Okay.
where some of the other ones are. So it's coming out of the system really quick. Ketamine is the same way. Now ketamine, if they have liver dysfunction, it might last a little bit longer, but both of those, you can kind of turn off and wake up pretty quick.
Okay.
Precedex is also short half-life, but a little bit longer acting. So like propofol, some patients will wake up within a few minutes. Same with ketamine. And it's also patient dependent. If the patient uses alcohol or drugs, then they might wake up a lot quicker. They might have a lot higher sedative needs because they're tolerant of those type of medications. And then there's also some patients, there's actually a gene, and it's usually in redheads. And it causes them to need a lot higher medication. I have that gene actually. My mom is a redhead and I have that gene. So when I've had surgeries, they have to give me like double the amount as normal. So it's just patient specific on how quick they wake up and how they metabolize it and how critically ill they are and what they've been on before they come into the hospital. Does that answer your question?
Yeah,
Okay,
thank
good.
you.
Wait, I have one too.
Mhm.
Can any of these be given on the floor? Or do
No.
they all have to be in ICU?
Precedex is the only one that can be given on the floor, and it's like half of the max rate. Once they go over 0.7, then they have to be in the unit. And that's only on step downs.
Oh, okay.
So no floors can have any of these IV sedation meds.
Thank goodness.
Okay, so fentanyls are opioid. We use it for pain. It does affect the respiratory drive, so the patient, if they're on a fentanyl drip, continuous drip, they must be intubated. We can do pushes without them being intubated, but that continual medication, we definitely need to have them intubated. It also can cause, if they've been on it for a long time, we saw this during COVID, when they come off of it, they can actually go through opioid withdrawal. So we come down really slow on it, or if we think the patient's gonna have continued pain, we'll put them on the patch. Transition from the drip to the patch. So our higher doses are gonna be more towards like 150 micrograms per hour. And that's patients that need the deeper sedation or, oh my goodness, I better just get this.
You're happy. We get it.
This is Corinne, how can I help you? I'm in a presentation. What do you need? Okay, all right, who is it on? Okay, I'll let pharmacy know. All right, thanks, bye. Dr. Organti's like, finally you picked up.
He doesn't care.
Oh, okay, so fentanyl, we're also worried about, I don't know if any of you have picked up on this on rounds, but patients that are on fentanyl drips and higher doses of opioids in general, it slows the bowels down. So we wanna make sure that we get patients bowel regimens that are on fentanyl. Also, we have our midazolam. Here's our benzodiazepine. We also use lorazepam pushes, but if a patient needs constant benzodiazepine, that is like a seizure patient or a patient that we're using this sedation on because we can't use propofol, like we have to switch them to midazolam as our sedative, we really like it. It's really good for seizures, but it also can cause respiratory depression. If you're on it a long time, we can go through benzodiazepine withdrawal, which can be a really serious medical condition. And in patients with poor, this is like kind of one of your questions, with poor kidney or hepatic function, this can hang around a long time. I mean, we're talking like days in those particular patients. So we try not to use it in that patient population, but sometimes we have no choice. Our higher doses are when we're getting up closer to 6+ per hour. That's a pretty whopping dose, and that's usually in our patients that are continually seizing and we're trying to control those seizures. The thing about why we use midazolam in a drip versus lorazepam in a drip, lorazepam IV, actually one of its excipients that causes it to go into liquid can cause toxicity, kidney toxicity. So if you're giving a ton of Ativan IV, then it can cause some kidney dysfunction. So that's why we use midazolam, because it does not have that. Okay, and Nimbex. I'm sure you all have probably heard about Nimbex, our paralytic that we use here. There are a few others, but this is the one we like. It has the best study profiles, best, what am I trying to say? Evidence to back it up. That was the word I was looking for. So patient must be deeply sedated. I mean, if you think about it and you're getting paralyzed and you're awake, that would be terrifying. So when on these patients, these are the patients we're running the super high doses of our sedatives. It causes your skeletal muscle to relax, so the patients can sync with the vent. So basically it's preventing all those skeletal muscles to completely relax so they cannot fight the vent at all. Other paralytics that we use for rapid intubation, we're gonna use rocuronium and succinylcholine. They all kind of work the same way. They're all skeletal muscle blockers, but we use the pushes for actual intubation versus someone that we want to actually keep paralyzed. It's different dose and different route. So I think some of you, especially during COVID, probably have heard our BIS monitoring in Train of 4. This is just kind of a quick explanation of how we know that our patient is really sedated properly. Because like I said, who wants to be paralyzed and awake? I don't think anybody would. That would be horrible. So how we actually find out that our patient is paralyzed, we do what's called train of 4. And it's actually like a little battery powered stimulator, and it has a small electrical current. And you can put it in a few different places. Sometimes they put it right here on the wrist, but since most of our patients are in restraints or under covers or there's IVs, we like to put it here. And it stimulates, and based on how many twitches there are, that's how sedated they are. So why we call it train of 4 is it sends 4 impulses. If the patient twitches 4 times, they're not very paralyzed. If the patient switches 3 times, they're about 75% paralyzed. 2 twitches, they're even more paralyzed, and so on and so forth. Twitches absent, 100% paralyzed. So usually our goal is gonna be a train of 4 of like 1 to 2. So we don't want them completely paralyzed, but we want them paralyzed enough that their muscles are not getting, their nerves are not going and their skeletal muscles are not moving. Now, so that's to know how paralyzed we are. To know how sedated we are, we wanna make sure we're fully sedated before we paralyze. We do the BIS monitoring. Have any of you seen that yet?
Yeah.
Or heard it? So it actually it collects raw EEG data, and they put like a strip on the patient's head and it connects to a machine, and a BIS with a value of 100, patient's fully awake. If you have a BIS of 0, there is no brain activity going on. You are way overly sedated. So 65 to 85 is normally recommended for sedation, but patients we want deeply sedated because they're paralyzed, our goal is 4 to 60. So it just kind of tells us how sedated we are so we can do the paralyzing. All right, now I know you all know a lot about this one. So our ICU delirium. Patients obviously get really confused for multiple reasons, and here we go. Infection, alcohol substance withdrawal, Wernicke's disease, metabolic, hypoglycemia, medications, trauma, neurocognitive issue, seizures, vascular issues, hypoxia, vitamin deficiencies, endocrinology issues, maybe their TSH is sky high, and then also possible toxins or heavy metal ingestion. So what do we want to do? We want to try and remove the causative agent, but we don't always know what it is, right? So we kind of have to just kind of go through and try and figure it out. We fix electrolytes, we take away certain medications that may be causing delirium. We're going to address sleep and wake cycles. That's why a lot of times you hear the doctors say, open up the windows, let's wake them up, let's get their sleep cycle back on a regular cycle. We're going to manage pain, we're going to address sensory impairments, encourage family visits, or not if they have one of those type of families, and we all know that happens sometimes, and early mobilization. We all know that is so important. So there's actually no identified therapies, medications, or interventions absolutely proven to decrease the duration of delirium, except, as you all probably know, mobilizing patients, if we can. Okay, so even though we have found that medications don't really work, sometimes we still have to use them. So in the ICU setting, even though there's no true evidence that the treatment with haloperidol will reduce the duration of delirium, it's still commonly used. In patients that are gonna harm themselves or a coworker, we will give Haldol, but there is some evidence that Seroquel works. So that's kind of why we, or in the atypical antipsychotics work, but it's still not robust enough to say, it's a jump go-to, put anybody that's delirious on an atypical antipsychotic. We're not gonna do that. That is, we wanna try and figure out everything else first. So we have our Haldol, like I talked about, that isn't proven to reduce the duration of delirium, but we do have to use sometimes. We have our Zyprexa, which is an atypical antipsychotic. It's a little bit better, but Seroquel is the one that actually does have a little bit of evidence. So, and we can give that PO. But sometimes patients can't take PO, so then we have to go to our Zyprexa or Haldol. And all of them can prolong the QTC interval, which then we worry about throwing them into torsades. Okay, so Precedex, also we use sometimes in patients that are confused. Like we had talked about, it has sedative purposes, also analgesic purposes, and it is useful for hyperactive delirium in patients that are going through withdrawal. It is really, really helpful for them. And then the side effect, as I talked before, bradycardia and hypotension. And we also have our short-acting benzodiazepines, which we really try to avoid because this can actually cause the opposite effect. It can make the delirium even worse sometimes, especially in elderly patients. But we still, every now and then, will use it. It's good with withdrawal because we're using it for our CWA patients. Oh, lovely. Okay, I'll just keep on going. You know, it's burning down, we'll figure it out. Okay, so we have our mild pain. We've got our Tylenol. Can you even hear me? Yeah, go ahead.
What is that Prexis?
Zyprexa is an atypical antipsychotic.
For those, when we have patients, like, how sedated should they be? Like Zyprexa, although, like, are they gonna be on for several hours? Because that's the thing, like,
It depends on the patient.
Okay, so there's.
It really does depend on the patient.
When you got it last night, it got overnight, and then like, try to see them morning, like, you know, through the day, and they're still not, so.
Yeah, it really depends on the patient and if they have an underlying psych issue or not. Because if they do have an underlying psych issue, they may be a little more tolerant to it, but some patients it just knocks out for a few hours. So it really is patient and dose dependent.
Seeing it's like, they're just not, they're not feeling out, and then like, that's what it's attributed to, is having received one of those medicines.
Yeah, it definitely, if you have a patient that is altered and not really waking up and they've had Haldol or Zyprexa, that's probably why. Because that's the whole idea, is to sedate them without using a sedation med, because you know, they'll just go to sleep and calm down, versus actually like needing to be intubated or something. Sometimes that happens too with extremely agitated patients.
Okay, so I've heard Dr. Rao a couple times, I've heard it in neuro step down, with our agitated neuro patients whose sleep-wake cycles are messed up.
Mhm.
He will advocate for Precedex at night for 2 nights in a row
Mm-hmm.
to get that. Does that make sense?
Yes, to
just get,
to help them fall asleep
yes, and get over.
and get their sleep cycle back on.
Okay, so that would not linger in the morning.
No,
Okay.
no, unless they were running it at way too high of a rate.
I mean, it's step down.
And then once they turn it off, they should wake up within
With that.
30 minutes to an hour.
Okay.
So we all know Tylenol, we don't give it in liver dysfunction. It's really good to start. I don't think we use enough of it, honestly, but it does work really well. It actually works in the central nervous system to block your pain receptors. So NSAIDs, we have our Toradol and our ibuprofen. We avoid those in a lot of patients because they can cause increase in bleeding, and they can cause ulcers. So, but it is really good for patients that have an inflammatory process going on. But we do worry about GI bleed. So then we have our moderate pain, like our low dose opioid IVs, our morphine, hydromorphone, and fentanyl. And then our low dose opioid PO meds, which we have Norco, Percocet, oxycodone. And hydromorphone can also be given PO. Now in our severe pain, we're gonna be given the higher doses. So that's where we worry more, especially with fentanyl, we worry about respiratory depression. They all can cause respiratory depression in higher doses, but we worry about fentanyl the most. And then our other pain options, we have lidocaine patches, tramadol. Tramadol is synthetic. The problem with tramadol is patients that have kidney dysfunction, it tends to accumulate and it can make them goofy. So if I see it on a patient's profile, like in the unit, I usually try to get it stopped unless they're on it at home because some patients don't react to it well. We also have our epidurals, our PCAs, and gabapentin, which is another one that can accumulate in renal dysfunction, and it is classic when we see a patient come down. And they'll be like, I don't know why this patient's twitching, and they'll be doing this. And it's gabapentin overdose. And the only way, because what will happen is the patient will be fine on their gabapentin dose, and then something happens to where their kidney function goes downhill, and then it accumulates. And the only way to get it off is dialysis or time. So that is something that the pharmacists every day are looking at, gabapentin dosing. Okay, so now we have our muscle relaxants. They obviously, that's what they do. They help skeletal muscles relax in a patient that is having spasms. But they also have some yucky CNS side effects. So they increase fall risk, especially in elderly. Both dosing for tizanidine and baclofen should be titrated up when initiated and titrated off when they're DC'd, because patients can go through some pretty nasty withdrawal so severe it can cause seizures. And both have to be adjusted for renal dysfunction. So tizanidine can cause hypotension, weakness, dizziness. Basically, that's kind of the same for all of these, is dizziness, solemnness, and hypotension. But baclofen, definitely seizure withdrawal is the biggest one. And for cyclobenzaprine, we worry about in patients with heart failure, it is inappropriate and it can actually cause heart block. So we don't like to use that in heart failure patients. And then Robaxin can actually lower the seizure threshold. So that's another one to be concerned about. And then the IV, if you remember me talking about an excipient, the IV lorazepam, that can accumulate. There's also one in the IV form to where we limit it to 3 days on Robaxin IV. Then they have to try something else, or they have to go to PO. Okay, I'll just briefly talk about thrombolytics, just because, obviously patients are gonna be on a bed rest for 24 hours after our thrombolytics. We have 2 different types that we use. We have our TPA, which is what we used to consistently use. Now we just use it for PEs. Now we have switched to TNK, and it's because it's a better drug and it's cheaper. So that's ultimately why we switched, and it's a lot easier to administer. TPA, you have to reconstitute, and it takes a while, and then it hangs over an hour. TNK, we just draw it and push it. So it's a much easier drug overall. Contraindications are, obviously, if you're bleeding from anywhere, had recent surgeries, history of a stroke, if you have intracranial neoplasm or an AVM, which you wouldn't probably know, but without a scan, known bleeding disorders, and severe uncontrolled hypertension. Because patients that are at risk of bleeding, patients that have super high blood pressure are already risk at head bleed, so then you give them a thrombolytic and their blood pressure is super high, we don't do that because the risk is too high. We have to get that blood pressure down before we give it. Then we have our oral anticoagulants. There are direct oral anticoagulant, or sometimes you'll hear the doctors call them DOACs. Is Eliquis, Xarelto, and I don't even know how to say this last one, Sabayasa, I guess. I don't know, we don't use that one here. They're reversed with Kcentra valvaxar, so sometimes you'll see patients like, they fell, they had a head bleed, they were on Eliquis at home, so they got Kcentra or valvaxar to reverse it. Pradaxa works different. Instead of affecting the clotting cascade from the 10A, like the DOACs do, it affects thrombin. So it inhibits thrombin. You inhibit thrombin, you're not gonna get a clot. These capsules, we can't open or crush because they come immediate release. I've actually seen this in a few patients and it caused bleeds. So that's something we're really, really concerned with. This one has its own agent called Praxbind, and it literally does just like it sounds. It binds Pradaxa. It's an injectable. It goes in and just binds it up so then it can't react on thrombin. Then we also have our warfarin. Warfarin is a vitamin K agonist. It was actually discovered because a farmer kept losing his cows started dying. And he's like, I don't know what is going on with this. And he's like, you know what, they're eating this hay, this different hay. So he took some of the hay in to a scientist, and they found actually from the hay not drying out and being kind of moldy and like damp, it had dimercurol in it, and that actually was causing the cows to bleed out. They were eating it so that was the start of warfarin. Scientists basically made it cleaner, then it was used as rat poison, and then we started giving it to humans. But it was our staple for many, many years because we didn't have these other agents. So we have to monitor INR, so it's kind of a bigger pain in the butt. So if their blood's too thin, their INR is gonna be high. If their blood is too thick, the INR is gonna be low. So it just takes a lot of monitoring and dose adjustments, and it's definitely a bigger pain than to get therapeutic than the other medications. And we reverse it with vitamin K. So our injectable anticoagulants, we have heparin drip. So patients that for some reason can't, they're high risk of bleed. The nice thing about heparin, we shut it off and it quits working. So it's pretty short half-life. Our Gatraban is synthetic heparin. Patients that have pork allergies, alpha-gal, beef allergies cannot have heparin. It's actually made from pork. So that's why. We put them on our Gatraban. Our Gatraban is fully synthetic, but it's also very, very expensive. So we try to start with heparin. In both, we draw labs and we adjust it based on labs. If your blood's too thick, we're gonna up the rate. If it's too thin, we're gonna decrease the rate. Heparin is reversed with protamine, and protamine's just an injectable drug that we can give, but it has a high, it can cause anaphylaxis because it is made from salmon sperm. So patients that have fish allergies, we can't give that to. It can cause anaphylaxis. Let's see, Lovenox. Lovenox is similar to heparin. It's basically heparin with a chain chopped off. So that's why they call it low molecular weight heparin. Because it's a shorter molecule basically. It works the same way as heparin, but it's given sub-Q. And what's really nice about it is then you don't have to have a continuous drip. You can get injected twice a day, or for just prophylaxis, injected only once a day. Okay, so reversal agents, I talked about protamine. That also works for Lovenox. Vitamin K, we're reversing warfarin. It's available IV or PO, works way quicker IV. And then K-Center, and I forgot to update this, now we use Valfaxar. They're basically the same thing, just a different company makes them. They're actual blood factors, so the blood factors actually help decrease what the warfarin and the DOACs are doing to the clotting cascade. Okay, so we also have our patients that are being treated for elevated ICP. Sometimes we use saline, sometimes we use mannitol. So hypertonic saline, we're gonna actually decrease the swelling in the brain by increasing the sodium in the blood. Basically the whole idea of osmotic gradients and just causing that brain to shrink a little bit. We monitor it really, really close every 4 hours. 3% is really irritating on a vein, so we try not to run it through a peripheral line for more than 48 to 72 hours. If they're gonna need it longer than that, I will ask for a central line if they're gonna need it for a while. We can also do bolus pushes, but that's really best. It's so concentrated that it's used for emergencies and patients only with a central line. We don't want the sodium to rise too fast, too quick. And the reason is it can demyelinate white matter and it will demyelinate the pons. And then the patient can die or be forever injured. So we try not to increase our sodium by more than, if the patient's hyponatremic, we don't like to do more than 8 in 24 hours. And then if we're treating ICP, we don't want to go over 12 an hour, 12 in 24 hours, excuse me. Mannitol is actually an osmotic diuretic. It actually pulls water through diuresis. So it's gonna cause the patient to just basically urinate off that extra water. And because of that, like any diuretic, it can drop blood pressure. So patients that are already low blood pressure, we don't wanna give mannitol to. We have to use, the funky thing about mannitol is it literally is it's like a sugar. So sometimes if the vials aren't warm, if they get cold, they will crystallize, and we can't use it if they crystallize. So it's kind of like honey. Like, have you ever had honey where it's cold and it like will not come out of the bottle? It crystallizes. It's the same idea. So we will actually throw it in a warmer and the crystals dissolve. But we use filter needles to draw it up. It's kind of a pain. Okay, let's see what's next. And that is it on the commonly used medications. Are there any questions? Yes.
What does the transition look like when they're leaving the ICU from a pharmacy standpoint?
Well, we're gonna make sure they're not on any vasopressors. We want their blood pressure stable. We don't want them on any sedatives. And most IV meds, we wanna try and switch to PO if at all possible. But we try to just kind of clean it up. We don't wanna be sending the patients out on anything that needs a lot of monitoring. Yes?
The lorazepam, isn't lorazepam used to help people with dementia oftentimes?
We really don't like to give it in patients with dementia because it can cause delirium.
Right, okay, I'm just remembering, my father-in-law had Alzheimer's, and they gave him lorazepam every night, and it like helped to calm him, but I guess if he wasn't delirious.
Yeah, if, I mean,